Dear audience, in the lecture we will talk about the circulatory system, mostly about the heart and the large vessels, and then the circulations. Let's start with the location of the heart. The heart is located in the thoracic cavity. Within the thoracic cavity, it takes place in the central part of that, what we call mediastinum, and the lower part of mediastinum, where the heart is located, called cardiac mediastinum. The heart, by the way, is covered by the pericardium. The pericardium is one of the three large serous membranes of the human body. Beside that, we have the pleura, which covers the lungs, and also the peritoneum, which covers the abdominal organs. Let's start the description of the heart with the outer surface. The grooves and the surfaces we will talk about first. On the front view, we can see the sternocostal surface. That's the biggest part of the anterior view. On the posterior view, it's not visible, of course, but from that direction we could see that. Next surface, called base of the heart. This is situated posteriorly, created mostly by the two atria. Anteriorly it's not visible, of course, but that arrow shows the approximate direction of that. The third large surface, called diaphragmatic surface. This is the surface where the heart sits on the diaphragm. On the anterior view, it would look like that. It's not a surface, but here we have to mention the apex of the heart, and then comes the grooves. The most important one is the coronary groove. The coronary groove goes around the heart, and here I would like to highlight that this large vessel, actually it's called pulmonary trunk, the coronary groove goes behind that. That's why I marked here by interrupted line. And also on the posterior surface, as I told, it goes around the heart. From the coronary groove, anteriorly opens the anterior interventricular groove, or sulcus, and posteriorly starts the posterior interventricular groove, or sulcus. Of course, the coronary groove also can be called coronary sulcus. After that, let's see the chambers and the large vessels of the heart. First of all, the right atrium, which is here on the front view and here on the back view. And here I would like to highlight an important part of that, what we call auricle. Into the right atrium drains the superior vena cava, which is here and here on the back view. And from inferior direction comes the inferior vena cava. And as you can see in the corner, the white arrow frame always marks those kind of vessels which carries deoxygenated, so venous kind of blood. The next chamber is the right ventricle, which is located here on the anterior and visible mostly there on the posterior view. Into the right, or from the right ventricle, the pulmonary trunk starts. That one is here. And from the pulmonary trunk, pulmonary arteries start to both directions. These are visible both anteriorly and both posteriorly. Next chamber is the left atrium. The left atrium, only a small portion visible on the anterior view. It's mostly located on the back part, and the anteriorly visible small portion called left auricle. As we had right auricle, this is the left. Into the left atrium drains the four, so two per side, pulmonary veins. Here you can see them, and here I would like to highlight that the black arrow frame always marks those kind of vessels which carries oxygenated blood, so arterial type of blood. The last chamber is the left ventricle, anteriorly and posteriorly, you can see that. And from the left ventricle starts the aorta, what you can see here on the front view and here on the back view. In the next slide, we can see the right half of the heart. Mostly the inner surface of these chambers we will see. On a quite strange drawing, the atlases and the books used to mark it. That's why I would like to explain how these strange cuts are made from the heart. Imagine that here we have a knife, and with that we can cut a small portion of the heart, remove that, and from the right side we can look into the chambers, and this is the result then. This is the cut surface. So that surface here is the same that this surface there. On this picture we can see the right atrium and the right ventricle too. In the right atrium we can see that the superior vena cava drains from above. This is the orifice, and then also we can see the inferior vena cava and its orifice. There is a third orifice in the right atrium. It's called coronary sinus. The coronary sinus is the largest vein of the heart, largest own vein of the heart, belongs to the own circulation. And to reach from the right atrium into the right ventricle, we need to pass the right atrioventricular orifice. In this orifice we have the tricuspid valve, which has three portions: cusp, chordae tendineae or tendinous cords, and papillary muscle. Later we will talk more about that. And we also can see here the beginning and the pulmonary trunk itself. Let's see the same in the right half of the chambers. That's also a quite strange view. Here is the knife, and now we just cut through the heart, and like a book we open it toward two directions. And we will look from the left side, and this is the result, how we can see the left half of the heart. This is the left atrium, and then this is the left ventricle. Here I would like to highlight your attention to the wall thickness of the left ventricle. This is the thickest walled chamber in the heart. The normal wall thickness is around 10 to 12 millimeters under normal circumstances. So into the left atrium, the pulmonary veins will drain. The two right you can see next to each other, and because of our strange cut, the two left pulmonary veins are far from each other on this kind of picture. That's why I try to explain that this is how we cut the heart on this kind of view. And just like the same that on the right side, to reach from the left atrium, the left ventricle, we need to pass the left atrioventricular orifice where the bicuspid or mitral valve is located. It also has the same three portions, so papillary muscle, chordae tendineae or tendinous cords, and the cusp itself. And there we could see the origin of the aorta. Toward that direction the aorta starts, but it is covered by the anterior cusp of the mitral valve on this picture. Let's talk about the valves of the heart then. Two kinds of valves we have, the cuspidal valves and the semilunar valves. Let's talk about the cuspidal first. These kind of valves we can find between the atria and the ventricles. About the parts of that we talked about twice. What we should know about these valves, that how do they work? They are open during diastole. This is that part of the heart phase when the atria contract and pushes the blood toward the ventricle. And then when the systole comes, when the ventricle contracts and tries to push the blood toward the large vessels, in our case now toward the aorta, because this picture is from the left side of the heart, but on the right side it will be the pulmonary trunk. So when the ventricle contracts and tries to push the blood toward the large vessels, this valve must be closed. The closure itself is made by the pressure change, so the blood will close the cusp. The function of the papillary muscle, when it contracts, it tenses the tendinous cords or chordae tendineae and tries to keep the cusp in the level of the orifice. So what the muscle do here, but the muscle function serves not to let the cusp to hit back toward the atrium. This is what you can see here by text, helping the learning at home. And after that, let's see the semilunar valves. These kind of valves we can find between the large ventricle, between the ventricles and the large vessels. they have two portions, the flaccid part and the tense part. The tense part is mostly immobile through the heart cycle. It does not change its shape and it won't move. The mobile part of the valve is the flaccid part, which has two sub-portions, the nodule and the lunule. The lunule gets its name mostly of that shape. It has a more or less half-moon shape, and when two lunules meet with each other, this is the nodule. How these portions work, how this valve works: during systole, this is the ventricle and this is the large vessel. During systole, the ventricle contracts and simply pushes the blood outward, and it's not so hard to imagine that in this case the flaccid part opens and lets the blood out, lets the blood upward, because the large vessels goes upward. And then during diastole, when the pressure is higher in the large vessel because the blood is there and the ventricle is almost empty, the blood tries to flow back through the valve, but in that case the blood itself will fill these pockets, and because of that the flaccid parts are moved toward each other, and this is how they close the way back to the ventricle without muscle function. This is what I would like to highlight, that here we need a muscle function and here we don't need any muscle function. This is mostly because of the difference in the pressure. Okay, right after that, let's see the blood supply of the heart. About the arteries we will talk. Previously we mentioned the coronary groove or coronary sulcus. As I told, it goes around the heart. And from that, posteriorly, we have the posterior interventricular groove. These lines are interrupted because the heart would cover them. And also the anterior interventricular groove. In the coronary groove, on the right side starts the right coronary artery, and on the left side, the left coronary artery, which starts in the coverage of this blue-colored vessel. I hope you remember that was the pulmonary trunk. So both coronary arteries start from the aorta. On the right, it's quite well visible, and we can imagine it easier. The left one also starts there, but runs behind the pulmonary trunk. Let's talk about the branches. Right coronary artery has two notable branches, the right marginal branch on the side of the heart, and in the posterior interventricular groove we have the same name artery, so posterior interventricular artery. From the left coronary artery we have two large branches, the circumflex branch, which is inside the coronary groove. It runs in the left side of that. And it also gives a branch to the anterior interventricular groove. This is the anterior interventricular branch, or also clinicians used to call it left anterior descending, or just simply LAD. Let's see what do these coronary arteries supply exactly. The left coronary artery supplies the left atrium, main part of the left ventricle, and a small portion of the right ventricle on the sternocostal surface. This surface was the sternocostal surface, and if you remember, that was the right ventricle and this is the left ventricle. So if the vessel comes here, for sure it will give branches toward the right ventricle. That's why we used to say a small portion of the right ventricle is also supplied by the left coronary artery. Opposite situation on the right coronary artery. Of course, it supplies the right atrium, the main part of the right ventricle, except this small portion because it's supplied by the left, and then a small portion of the left ventricle on the diaphragmatic surface. The same situation on the backward. This is the right ventricle, this is the left ventricle. If the vessel comes here on the border, that will give branches toward the left ventricle also. Some clinical importance, here you can see a star. The star marks the anterior interventricular branch, which is responsible for most of the heart infarctions because the obstruction of this vessel causes them. That's why the nickname of this artery among clinicians is Widowmaker. Let's talk about the innervation and the impulse formation and conduction system. And here I would like to separate them, and let's talk about the impulse formation and conduction system. It's important to know that the heart has automacy. These terms mean that the heart is able to work independently from the outer innervation or any kind of outer impact because of its own impulse formation system. However, we need to regulate the heart, and that's why we need mostly innervation. Also, the hormonal system has some impact on the heart, but the innervation is much more important. Why do we need to impact the heart's function? Because different heart frequency and different contraction power we need if we are running in front of the lion in the African savanna, or we are just sitting on the couch in front of the TV. So that's why the heart has sympathetic and parasympathetic innervation. If the sympathetic innervation becomes active, the heart frequency and the power of contraction increase. In case of the parasympathetic impulse, the frequency and the power of the contraction decrease. The sympathetic innervation comes from the sympathetic trunk, while the parasympathetic innervation comes from the vagus nerve, which is the cranial nerve number 10. CN means cranial nerve. And then let's turn back to the impulse formation and conduction system. The highest center of that is the sinuatrial, or just simply abbreviated to SA node. This node is located in the wall of the right atrium. From here, the impulse goes to the atrioventricular, that's why called AV node, which is located in the interatrial septum. That's the septum between the atria. From here starts the bundle of His, which runs in the interventricular septum, and from that comes the bundles of Tavara. We have a left and the right. It's quite good to know that the left later gives two branches. And then from the bundle of Tavara starts the Purkinje fibers. In several sources you can read that Purkinje fibers will innervate all the cardiac muscle cells. This is not true. The cardiac muscle cells are also able to give the impulse to each other. So we have much less Purkinje fibers than as many cardiac muscle cells we have. And some clinical importance here, because of the automacy of the heart transplantation itself is easier than it could be. I wouldn't say easy. And maybe you heard the term arrhythmia. This is also caused by the problem or mistake of the impulse formation and conduction system. Let's talk about the blood circulations. Two kinds of circulations we have. On the back view of the heart, I will show them. The first circulation, called pulmonary circulation. Here I would like to mark that the blood starting in this system is venous-like, so the oxygen content is low, and as we go in this pulmonary circulation, its oxygen level increase. This is the function of the pulmonary circulation, to re-oxygenize the blood arriving back from the body. So where do we start from? We start from the right ventricle. Right ventricle will give the pulmonary trunk. This is less visible, but we can see well here that the pulmonary arteries start from the pulmonary trunk. Their color is blue because here, as I told you, the blood is deoxygenated, so venous kind of blood we have. That kind of blood we will push into the lungs, where the gas exchange happens and the blood gets re-oxygenized, so its oxygen level increase, the carbohydrate level decrease. This oxygenated blood travels back to the heart, into the left atrium, more precisely through the pulmonary veins. Here I would like to highlight that these vessels, called arteries, however, they carry venous blood, and the pulmonary veins, however, they called veins, they will carry oxygenated, so arterious type of blood. And from the left atrium, as we step into the left ventricle, here we'll start the systemic circulation. Opposite situation we have. Here the blood is oxygenated, and we will send it to the body, and the body will use this oxygen and will send back send back venous kind of blood to the heart. So we start from the left ventricle. Left ventricle gives the aorta, and aorta with its branches supplies the upper half of the body, so the upper limbs, head and the neck, and with other branches supplies the trunk and the lower limbs. These body parts will use this oxygen and will send back venous blood to the heart, the superior part of the body through the superior vena cava, and the lower body part through the inferior vena cava. And then this blood arrives back to the right atrium, and the right atrium, when it sends the blood down to the right ventricle, we go back to the pulmonary circulation again. Here I would like to highlight two terms, vasoconstriction and vasodilation. Vasoconstriction means that the vascular smooth muscle contracts. That will increase the blood pressure because same amount of blood tries to go through a smaller diameter tube that will cause a higher pressure. And the vasodilation is the opposite situation. The vascular smooth muscle in this case relaxes, and that's why the blood pressure decreases. This is the easiest way to regulate the blood pressure. Finally, let's talk some words about the lymphatic circulation. However, in another lecture you will hear more about that, but I would like you to see the whole thing together. So as we told, the arteries come from the heart. They will capillarize, serve the organs, and the capillary system turns to the veins, and the veins will travel back to the heart. However, we have to know that on the levels of capillaries, not only oxygen and nutrients will leave the circulatory system, but also some blood plasma, so some fluid leaves the circulation. This is how I mark that the arteries are thicker altogether than the veins. So we have a higher blood volume in the arteries than in the veins. The difference is here in the interstitial spaces, so between the cells. Of course, that system cannot work alone after that, because we would permanently lose fluid toward the body, and that's why less and less fluid content we would have in the circulatory system. That's why we need a third circulation, the lymphatic circulation, which starts with these blind and lymphatic capillaries. They will lead this additional fluid from the interstitial space, and these will enter back to the venous circulation, leading back the lost fluid into the circulation. And here, if we have this secondary circulation, evolution figured out that we have lymph nodes packed to that circulation, which can filtrate that fluid, searching and killing for pathogens. That's a schematic picture about the lymph circulation. I only would like to highlight here the largest lymphatic vessel that's called thoracic duct. And thoracic duct, as I previously showed here, will drain back to one of the large veins of the heart. This is how this extra fluid reaches back to the venous circulation. Some clinical importance also here. First of all, the edema as an everyday life happening. This is what I tried to explain you, that we lose fluid here on the level of capillaries, and if we have any problem with the lymph capillaries or any problem with their fluid content, the fluid remains in the interstitial spaces, and that will create a larger volume of the limbs. This is what we call edema. And second, maybe even more important, that the tumors create metastasis through the way of lymphatic circulation. But as I told you about this circulation, you will hear again in another lecture. And finally, before I would like to say thank you, I would like to highlight that if you choose Page as the place of your studies, do not miss the surroundings of Page and the scenic views of the Mecsek Mountain, the János Lookout Tower, and the Kistubes view place. These both of these places you can visit with a simple walk. So thank you for your attention.